But I'm going to just move on, and since we've had this wonderful conversation to understand sort of the real world impact, right? I want to introduce our resident experts who are really the thought leaders thinking about, okay, if not quality, what? How do we do this better? What are we thinking about in terms of better patient engagement? And I think about what Corey was talking about earlier around the science of patient engagement and the methods, right? Because that's where we hope we're going next, right? So I'm going to first introduce Dr. Elisabeth Oerlein, Assistant Vice President of Research and Programs at the National Health Council. She is a mixed methods researcher with expertise in value health technology assessment, outcomes research, patient-focused medical product development. And today she's going to present to us information on the National Health Council's work related to value assessment. And then we're going to hear from Dr. Richard Z, a health economist serving as the Health Economics and Outcomes Research Manager for the Innovation and Value Initiative. And he is going to present to us information about the work that's being done at IDI, which is also very focused on how we capture the patient voice and value. So I'm going to start with Elisabeth, if you don't mind. I think we have her slides.
Mm-hmm. Sarah, you're on mute.
I'm sorry, just direct us when you need us to move the slide forward. Sorry, thank you.
Great. Thanks so much, Sarah. And thank you to those who presented early. I really appreciated your remarks, and also bringing this back to what's so important is thinking about the individuals who can be impacted when value assessment isn't done in a patient-centered way. So I'm just going to wait on my slides, but I can just go ahead and get started by centering us about, what's the goal that we should all be working towards? And I think we're very aligned that it should be facilitating access to treatments that patients need at prices that they can afford, and that we would acknowledge that there's really nothing worse than having effective treatments available, but not being able to have equitable access to them. And so, this is a conversation about methods. And so I think it's helpful also to start off with what's the definition of value assessment, and what are the different potential methodologies that can be used to assess value of treatments, of surgeries, of hospital-based care, and so on and so forth. And so I think it's really important that we remember that we're trying to bring together folks with all different types of backgrounds. Value assessment should certainly be multidisciplinary, and we're wanting to evaluate clinical, economic, social, organizational, as well as ethical issues for a specific health intervention or health technology. That might be a drug or a surgery, something else. And it can involve a review of the clinical evidence. It can involve the review of healthcare costs, and then social and ethical impacts on the healthcare system and the lives of patients. And so it's important to also acknowledge that the current methods that we use to conduct value assessment all have limitations. And so at the NHC, we're really focused on identifying and promoting patient centricity and value assessment across different methodologies. And so we've been working on this by preparing patients to engage in conversations around value assessment, partnering with members of the research community to improve methodologies, advancing the data environment to ensure it supports patient-centered value assessment, and then certainly also pushing for transparency in analyses as well as decision-making. And so you can see here on this slide, this is the National Health Council Value Classroom. And the intent of this is really to provide a free resource for members of the patient community, as well as others who are new to value assessment. And what we've tried to do with this website is to present, we've got our course, which is a series of online modules. That's Health Econ 101. We do have one of the modules about the mysterious quality adjusted life year that I think does a pretty nice job of explaining the intricacies of how it's used, what some of the challenges can be in terms of the data that goes into actually calculating a quality adjusted life year, as well as the larger how it fits into a larger cost effectiveness analysis. So that might be of particular interest to folks, but there's also other topics included there. We have a glossary, and then we have a number of other tools. And so these are really helpful, especially in the case of, if you are representing a chronic condition, patients with a chronic condition, and there's a value assessment that is about to happen. That might be ICER conducting a value assessment. It might be partnering with IVI. You'll hear from Richard in a couple of minutes. But it's intended to provide resources for you to get ready. We've got the Get Ready checklist, which is part of it, which discusses some data collection partnerships you might want to consider, as well as thinking about how do you write really effective comments if you're actually reacting to a specific value assessment. And so that would be within our considerations guide. I'm happy to pop a link to that in the chat in just a minute. We can go to the next slide, please. Okay, and then I mentioned at the top that another, huge part of our effort in terms of enhancing patient centricity of value assessment is really in terms of methods development. And so here I've listed out a number of our collaborators within value assessment specifically. You can see, on the left is a white paper that we did, and this was about multi-criteria decision analysis. So we've spoken a lot about quality adjusted life years as one type of input into a particular way of conducting a value assessment. But there's other methods as well. And so it's really important that as we're evaluating any possible methods for conducting value assessment, that we're keeping those same things in mind as, is this a patient-centered methodology? Are the data that are being used as part of the assessment patient-centered? Is the output being presented in a way that's understandable as well as transparent about limitations? And so that was an approach where we wanted to look at MCDA as a method. You'll hear much more about the work IVI is doing in that space. But we have a number of other ongoing initiatives and partnerships. Health Technology Assessment International is a professional group, and it might be of interest to folks on the call that, it's an opportunity for us to also work internationally on these issues. HTA, or value assessment, has been used in other countries around the world as well for a number of years. So there's some good insights that we can glean from approaches to patient engagement and data collection methods from those abroad as well. And so I am actually going to stop there because I know we're running a little bit short on time, and there's a couple of questions later that we want to go through. So if we go to the next slide, you'll be able to just see my email address. Happy to follow up about any of these, but otherwise I'll turn it over to Richard.
All right, Richard, we're going to get your slides up here momentarily.
Sure.
So that you can also present some information to the group, and just excited to have you both. Thank you.
Thank you for the invitation, and thank you, Elizabeth, for a great presentation to set the scene. Can you guys all hear me okay?
Yes.
Hi, good afternoon. Oh, cool. Good afternoon, everyone. It's a great pleasure to be here today. My name is Richard. I am the research manager at IVI. So for my presentation today, what I wanted to share with you guys is some of the novel approaches to advanced patient-centered value assessment in the United States context. So to start off the presentation today, what I wanted to share with you is the set of 9 principles that IVI has developed to inform or guide the methods, that will provide insights to value assessment in the US context. So I won't go through all 9 here, but there are 2 I especially wanted to highlight today. One is sustain authentic patient centricity. And what this means, which I will illustrate with some examples in a little bit, is that the patient voices, the patient input, needs to be incorporated and solicited throughout the development and application of these methods. The second thing is health equity. So the COVID pandemic has really highlighted the widening disparities in our society. And very often we focus on population averages, but we do not really look into the subgroup specific inputs and also the implications a policy on disparities across subgroups. So there is also a need to really incorporate the equity considerations in anything we do. So these are the two I wanted to highlight. And now I'm going to go ahead and share some examples with you. Next slide, please. So one of the major initiatives at IBI is the open source value platform, which is kind of like a little laboratory which we use to test novel methods and approaches. So our current effort is a multi-stakeholder engagement effort to develop a value platform for people with major depressive disorder. And this platform really has two modules. One is the health economic module. The second one is the multi-criteria decision analysis module, which Elisabeth has also mentioned. So for this effort, there are three uniqueness about this effort that I wanted to share. The first is we have actually convened a group of 20 members, advisory group, who comes from different stakeholder perspectives in the United States. And from the outset, they guide us through this model development. And the point here is to really incorporate the decision context and inputs, from different stakeholders in the US. The second thing is, in parallel to developing this model, we have a collaboration with researchers from Pace Center at University of Maryland. And what we're doing there is to directly elicit inputs from a very representative patient sample and make sure that these inputs are incorporated into our both modules. And thirdly, for people, the general public, we also set up multiple points throughout the milestones for this project. As a matter of fact, right now, today, we're launching our public comment period for our draft protocol. And we have tailored in a way such that different stakeholders can provide input, especially the patients. So these are, some of the ways in which we're hoping to test and see how we can change the value assessment models. Next slide, please. So as you guys gather, an important part of our research portfolio is how do we crowdsource patient input and then put it into these methods contexts. And I only listed two examples here. One is economic modeling, the other one is MCDA, and those are two big areas that we're pushing on. But there are much more than this. There are other methods. So the challenge here from our standpoint is really two things. One is how do you operationalize this? The second thing is by incorporating these inputs, what difference does it make when it comes to decision context? So, next slide, please. So a very specific example I want to share with you is one of our ongoing collaboration with the researchers from Brand Corporation. And what we do here is we try to use goal attainment scaling, which is a well-validated survey instrument that just talks to the patient and asks them about what their goals are. And what we're doing here is we're exploring a model where we're training the patient advocates or the patient representatives in different communities, and then they can do outreach to more patients. So it's kind of like a hub and spoke model, as you can see here. So and through doing this, we're hoping to crowdsource patient goals and then aggregate it into these more population-based methods. And in this context, specifically, is MCDA. So to inform as the criteria and the weights for different criteria that you will use to solve the decision problem. So that is one example here. And next slide, please. I'm sorry, I'm rushing through all these things. And the very last one I want to share with you is not only do we want to test these methods, throughout this process, we also want to share our learning, but also make sure that we hear from different stakeholders. So one of the very exciting initiatives for IBI lately is a PCORI-funded Methods Summit. And this is a summit that's really focused on how patient preference data can intersect with health equity. We're still digesting the findings from this Methods Summit, but there are two very important learnings that I wanted to share today. One is we should really work with the patient communities about defining the meaningful impact of a disease and its treatment. The second is we really need more specific methods and metrics that can inform value assessment and comparative research. So on that note, I hope this gives you a sense of how we are pushing for more patient-centered value assessment in the U.S. context. And now I'm going to end my presentation here and happy to engage in the discussion.
That was great. Thank you so much, both of you. You know, when I hear you speak, I mean, because we often get this, you know, oh, there's no other way to do this, sort of assumptions. And I come back to something that Megan said, and when Megan and Jim were sort of in their final comments on the last panel, what is it? I mean, why can't we get past this sort of quality issue? I know when oftentimes in audiences of health economists and academics, they'll say, well, qualities are the gold standard. This is, you know, it's sort of like this is what they're educated to do, and they don't understand why we don't think it's okay, you know. And I think on this, where you know, we hope that everybody's learning, but what's the holdup? What do you think is the problem getting past this metric so we can get to what you're doing, which seems so much better?
Perhaps I can.
Why don't you start?
Sarah, you're muted. Perhaps
Richard,
I can start here. Yeah, sure, absolutely. So I think from my perspective, I think I'm thinking from the context of decision maker. There is a need for them to aggregate the individual inputs. There's a universe of data and input out there. So there is that need to kind of simplify and aggregate to some decision rules that will allow us to make more informed decisions. And here I also want to take a step back to think about quality itself. And by the way, I totally agree with what the previous speakers have said. And I think it's well acknowledged, you know, in the research community and also end user community that quality has its limitations and all the discriminatory implications. But if you think about quality conceptually, originally it was a beautiful concept, because if you think about the health benefits, you can really think in two dimensions. One is, you know, life expectancy. The second is the quality of life. However, it is in the measurement of these different aspects that it has all these unintended consequences. So I think the bigger issue from my perspective is the over-reliance, you know, on one metric to inform decision. Because every metric, you know, every novel method will have some sort of limitations. So what is really important is for decision makers to really consider a comprehensive range of outcome metrics. And, you know, whether quality is included or not, that is depending on the specific context. But there are all these clinical economic metrics that the decision makers should consider. So for example, in IVI's MDD model, what we do is we have 10 to 12 metrics that the decision makers can compare and look at them. So the danger, I think, from my perspective, is because of the limitation. If you rely on one metric overly, then it might lead to consequences such as, you know, disparities and discriminatory coverage policies.
So I'm happy to chime in too, and I agree with Richard. I think one of the challenges has been with cost effectiveness analysis or quality-based measures is that it's somehow kind of morphed into something where it is the decision instead of a tool that can be used as part of decision making, where, you know, you might have 5 or 6 different sources of data, and then you say, oh yeah, that's helpful, but you know, what I'm hearing over here is a little bit contradictory to that. So we're going to land somewhere in the middle. And so I think that would be a more productive way of talking about, and in, you know, using quality adjusted life years or cost effectiveness analysis as part of value assessment would be to have that more nuanced, transparent conversation, and to be very clear that, you know, oftentimes the data underlying how qualities are being calculated really isn't that great. It's not something that we would necessarily want our own decisions being made off of. And so I think we need to be really clear about that also as researchers, that, you know, it's the survey instruments that are used as part of calculating quality adjusted life years oftentimes are generic measures that aren't intended to or they're intended, but they may not be very high quality for disease-specific decision making. And so I think there's a lot of folks, many of the folks on the line have been out saying, you guys need to pay attention to these issues. These aren't little things that we can just let slide, especially if this is going to be something that's really guiding decisions, in my opinion, inappropriately so. But I think, Sarah, your point is, many of us who have been trained in pharmacoeconomics, we did learn these types of analyses as graduate students. And so, they're comfortable. I think one of the other challenges and is really in the importance actually of working kind of on the international level with groups like HTAI as well, is to see that, it's one model. NICE in the UK uses this model. Some of the other HTAs abroad use cost effectiveness analysis, but some of them say absolutely not. That is not something that we think is appropriate for decisions within our country, and we're not going to use that particular type of analysis for our decisions. So I think it's really helpful for us to learn from those experiences and to try to take some of those insights here as we're expanding the methods. And then finally, I'll just close with, I think that the efforts that PCORI now is going to be funding in terms of enhancing the data landscape will be so helpful for us in terms of making analyses that even those analyses that use cost effectiveness or qualities, making those better reflect patients' experiences and costs that matter to patients, which is obviously a very important input into all of this. And then also multi-criteria decision analysis, making sure that we actually have the data so that we can conduct these analyses more quickly. We don't have to go out and try to go over here for this data source, over there for that data source. And I'm sure Richard has many more perspectives on that, as somebody leading much of that work as well.
Elisabeth, if I may just also echo your last point, is I think the challenge, for example, at IVI is also exactly as you said, how to operationalize and demonstrate the impact. And Sarah, I think that might also answer your question about why that inertia, why that resistance change, because some of these novel methods do need to be demonstrated, do need to be tested before we can put them into practice.
Yeah, I mean, and listening to this, I think about the work that you're doing and how, were it not for work like what the National Council on Disability is doing to highlight how the quality fundamentally discriminates. And I liked how Andre Gallegos described it as both in design and impact, right? But were it not for that advocacy and were it not for efforts to try to take the quality equation out of decision-making, would we be in this place where we're actually starting to have discussions around alternative methods, better methods, right? I mean, looking at PCORI, one of the most exciting things about PCORI to me is that, especially now with their reauthorization statute, they're much more engaged now in this methods discussion, because there really is no good standards for what a good method looks like, which we need, I would think, right? I'm curious what you think about that.
Yeah, I think for me, one of the kind of most impactful things that has stood with me was a patient advocate who said, I think we'll know it's good enough when an individual patient picks up a value assessment and says, it's not perfect, but they did a pretty good job of reflecting my experiences in this analysis. And so the further that we can get towards that sort of gold North Star, I think that the better off we'll be. And I think, that's what the advocates on the line are pushing for, is we understand that we need a sustainable health environment. We understand that there are going to be trade-offs that need to be made. But we also need to make sure that if there are treatments that are available that have been approved and have been shown to be effective in populations, that we've just got to figure out a better way of making that clear and making that come out in decision making as well.
And I absolutely agree with Elisabeth's viewpoint. So And I think, as you can see from IVI's work, and that's also something we're trying to do, is to engage patients throughout the process, to translate the technical language in a way such that we can get patients' feedback and buy-in in the design of these methods, and also to ensure that the insights can also benefit the patient community ultimately. And of course, throughout this process, what we're doing is also, for example, even for areas which we don't have data inputs on that matter to patients, we should build in, for example, in the modeling context, like structural considerations or placeholders. So this way we can highlight areas where this gives the research community a kind of a future area, for potential research and highlight all these gaps. So I think that's largely based on our experiences too.
Yeah, I think one thing I'm hearing then, and I think everyone agrees on, is this concept of patient engagement, right? How do you capture the patient voice? How do you make sure that we're looking at caregiving costs? We're looking at whether or not you can go to work, right? Or but then again, for some patients, it's, can I sit up in bed? It is not a one size fits all. I appreciate the work that you're doing in that regard. I'm curious, from your perspective in terms of methods, right? Like, how do we get to a place where we just have better methods for getting that patient voice incorporated? Because we're really not, and the types of quality, especially in the quality-based analyses that we see out there, we're not doing a good job. I think we can agree on that, I hope.
Yeah, I think so. At the NHC, and also, in largely in partnership with IVI and others, we've been leading 2 initiatives to improve the methods collection, or methods for data collection. One of them is we just released on our website a patient experience mapping toolbox. And what that includes are interview guides and visuals to help researchers do a good job of comprehensively understanding what are patient experiences before getting a diagnosis, while getting a diagnosis, and then living with and treating a chronic condition. And that includes, costs, access, barriers, care coordination, all of that. And so we've put that on our website, and that's available for free for anybody to use. And so I think that that's one step towards getting more predictable and standardized way of gleaning qualitative information, which I think has been sort of a barrier, is that that's been all over the map. Another effort that we're leading in collaboration with IVI, as well as Every Life, and many others who have joined the project now, is to develop an approach for patient-centered core impact sets. And so to your point, Sarah, that there's all these different impacts that really matter to patients, and those might be disease specific or they might be across the board. And so what we're trying to do is to identify what are those impacts? And that's very deliberately broad, so that it can include health outcomes, and it can include costs of care. It can include things like modifying your car because you need to accommodate a wheelchair or something else. What are those things that matter to patients? And then to ensure that those that data on those impacts are consistently collected across studies, so that once they get to the health economists, once they get to the others who are going to be analyzing information as part of value assessment or as part of clinical practice guideline development or all of these other potential uses, that it's coming to them in a way that's structured and that reflects what matters to patients, and that it's high quality enough that we don't keep running against this wall where it's like, well, I hear you that that's important, but I just don't have data to support that, which, makes all of us want to jump off a bridge sometimes and say, what are you talking about? Your data is not high quality either, but you're very comfortable using that. So so that's, my 2 cents and some of the work that we've been doing in this area as well.
And to add to what Elisabeth said, the first thing is I'm really excited about the patient core impact, and I think it's really going to provide a blueprint to guide, the different disease states, and as different researchers think about values assessment, the different parts of that process. What I will, in addition, share is, 2 specific examples in which we're trying to operationalize, patient input in the context of value assessment. One of them is the goal attainment scaling that I briefly introduced in the presentation. The second is our collaboration with researchers from the PACE Center at University of Maryland. And what we're trying to do there is to elicit a set of treatment priorities for patients in a disease state of major depressive disorder. And then we're trying to see in what ways can we incorporate that as in the economic model. This could be an outcome. This could be a structural consideration that reflects patient journey. So these are just like some of the specific examples. And then I think largely another reflection I've had recently is, at what stage of the research should we really involve patients and engage with patients? And I think we could have done a better job at least two stages. One is in the conceptualization of the study design and the purpose of it. Because very often, as Elisabeth talked about, researchers go to do a lit search and they said this is available data. So we fit a model or we fit kind of approach to available data. But what should really happen is we should understand more of the nuance, of the burden of the disease, the impact of treatments on patients. And then we can triangulate that with available evidence. And that can really guide our research design to make sure that it's comprehensive, it reflects the real world patient experiences. The second part I think that's missing is once we have the results. So if you think about a patient survey study, we collect the input, but we don't really take those results back with the patient community and discuss with them what the implications are. Does this really make economic sense? What's missing? So that's also, I think, a missed opportunity where, as researchers, I feel like we could do better. And that's actually something we're aiming to do in our research project. Yeah.
You guys are awesome. Okay, one last, and then we're gonna end this thing. One last question. So I'm thinking about everything that you're saying because I completely agree, right? You have, and you guys are the masters in terms of thinking about this in the context of methods too. How do you get payers though, decision makers, people who actually are now taking this information and then translating it into something that makes a difference to whether a patient has access to care, right? How do we get payers to use better information to make decisions? How are we going to get, I guess maybe we don't have the answer, but I'm just curious what your thoughts are.
Perhaps I can start because I think that's the challenge we're facing, in a lot of our ongoing projects right now. And I think two things we can do incremental steps. One is to engage the peers from outside, such as the NBD model, so we know what the decision needs are. And second, because they are involved from day one, it's not a black box. There's a lot of communication exchanges among different stakeholders in that process. So that would hopefully lead to buy-in down the road. The second is I think there's a need to do pilot testing and to demonstrate the impact. So like with the NBD model, a specific example is if we were to solve the same question, what is the insights from a cost-effective analysis? What's the insight from NCBA? What if I consider caregiver costs? How does that affect all these treatment sequences that we should give to patients? So I think by realistically demonstrating this and how that's going to impact more cost-effective resource allocation in our society, I think that's where we get a mindset shift and in the practice of coverage and reimbursement decisions. Yeah.
So I certainly don't have a great answer to this. I wish I did. But one way we've been approaching this is because we really haven't gotten a lot of traction and interest from insurers in this area. But we've been partnering with employers in this area because in many cases, employers are interested in many of the same things that patients are interested in. They're interested in having their employees present. They're interested in making sure that their employees are productive, that, mental health considerations. And, I think we're at a moment right now where we probably have a very good opportunity to get employers even more on board with those types of considerations as they're looking to retain employees, as they're looking to bring in new employees. And so I think that that's one, alternative route to getting at health insurers is to get at the employers and say, you care about this stuff. You're paying for health care for so many people in this country. And let's make it better together. So that's one way that I hope that we, continue to move over the coming years as well.
Well, thanks to you both. I found that very educational. As we wrap up, I just, want to point people back to the website and the email that we sent out that had some resources, but you should also check out the National Health Council and Innovation and Value Initiative websites. They have some really great information there. I can say we're just really excited and grateful too for the National Council on Disability who presented earlier today. I think the presentation from Chairman Gallegos really, I hope, was a good sort of 101 on what's equality, why is it a challenge, and why is the disability community so focused on eliminating its use in our federal programs. And then I'm excited to see, I think some of that advocacy is why we're here today, right? It's why we're having a conversation about developing better methods. So anyway, we're very grateful because there are a lot of great minds and great advocates out there, thinking about this and trying to come up with solutions and to do a better job at the state and federal level. So thank you for everything that you do. We're going to end the forum here. But again, we hope that you'll stay in touch and let us know if you have any questions. Thank you.